Good evening, everybody. Thank you for connecting to the webinar, The Connection Between Internal Medicine and Lifestyle Medicine, organized by the EFIM Early Career Group. We hope that during this webinar, together with our distinguished speakers, we will discover how lifestyle medicine can enrich the internal medicine practice.
Good evening, everyone, and thank you for joining us for this session. Our discussion will be moderated by Dr. Alina Dima, a clinician specialized in internal medicine and rheumatology, fellow of the European Federation of Internal Medicine and member of the EFIM Early Career Group Subcommittee, together with myself, Tărăburcă Mihaela, a third-year internal medicine resident doctor in Cluj-Napoca, Romania. I will share with you some details about the structure of the webinar. So during the webinar, each speaker will present their topic for about 20 minutes. After all the presentations, we will have a 30-minute discussion session. You are welcome to write your questions in the Zoom chat at any time, and the speakers will answer them during the discussion session. We are delighted to open today's program with Dr. Emanuela Mercore Huțanu, family medicine specialist and IBLM certified lifestyle medicine physician. Dr. Mercore Huțanu is the president and the founder of the Romanian Society of Lifestyle Medicine, as well as a co-founder of the Moldovan Society of Lifestyle Medicine and a trustee of the European Lifestyle Medicine Council, as well as a member of several leading organizations in the field. Today, Dr. Mercore Huțanu will share her insights about the field of lifestyle medicine. And by the way, she also prepared a surprise for us. Dr. Mercore Huțanu, thank you for joining us today, and the virtual stage is yours. Please.
Okay, I hope now everybody can hear me. Hello, everybody. Good evening, good morning, good afternoon, depending on your time zone from where you are listening to us. I'm thrilled to have this opportunity to speak along with my colleagues, Simon Metis and Catalina Figueroa, about lifestyle medicine to internal medicine physicians. So it's our honor and happiness to share with you some things about lifestyle medicine. Thank you, Mihaela, for your kind introduction. Well, I have a surprise for our audience, but I will start a little bit to give some details regarding my background, because I think, first of all, we have to know each other and to understand how every body came into this world of lifestyle medicine. So, from my behalf, I will let you know just some details regarding how I discovered my own experience with lifestyle medicine. As Mihaela told you already, I'm the founder, president of the Romanian Society of Lifestyle Medicine, one of the trustee members of the European Lifestyle Medicine Council, and a member of Lifestyle Medicine Global Organization and the WLMO. I'm working with international colleagues, not only to develop lifestyle medicine in Romania and in Moldova, because we recently opened the organization in Republica Moldova as well, but also worldwide. So I have the opportunity to know amazing people like Catalina and Simon, true pioneers in lifestyle medicine around the world that are developing this amazing medical field. So to make sure you are seeing my slides, can you see some emergency picture here?
Yes, it's very
okay. So how I started? Well, after I finished medical school in Romania, I was a little bit, unsure what road I will pick for my mission. But usually the road is picking you, and not vice versa. And even though I started in emergency medicine as a doctor, and now I have more than 5 years experience in this, and I'm talking about pre-hospital and in-hospital emergency. Well, I quickly understood that my mission is, or my impact is very poor because I was having one-to-one impact to the people. This sometimes, gave me a lot of, how you call it, paying back in terms of when for real I could contribute to save somebody's life. But in general, I have to admit that I felt not enough because I knew that the majority of the people I was seeing in the emergency in Romania, I mean, there was, a chronic condition that were decompensating, and all these people could be saved if lifestyle medicine would be the foundation of our approach. So yeah, I was shifting little by little from this kind of work to see people that are eating pills, not taking pills, to something that I envision as a young doctor. My story began actually in 2018 when being in DC, in Barnard Medical Center, I was shadowing Dr. James Loomis. You must know him from the Game Changers, and also Neil Barnard, a very, very well respected researcher in terms of lifestyle medicine. So that was the moment when lifestyle medicine came to my ears. And ever since there, I was trying to bring the best practices in terms of prevention from all over the world, from Japan to Europe and so on, to give my patients the holistic approach, the whole person care that I was envisioning that I will do when I will practice. Of course, we also have our own, examples in Romania, in our families, all over in Europe, that our grandfathers used to live a very good life, even though they had difficult times to pass. The problem is that times are changing and sometimes are not going in our health, and we became more sedentary. The food is becoming less and less qualitative. We are not anymore connected with our folks. We don't have any more purpose in life to wake up from our beds in the morning. So I think many of us feel a little bit unhappy with our own lifestyle and our own medical approach with our patients. I had many times this feeling that I was just mopping the floor in a room that was flooding by water and asking for help from my neurologist colleagues or cardiologist or I don't know, pediatrician, but in the end, we couldn't address the root cause of the disease because we are trained usually to synchronize some symptoms and with some pharmacological treatments, which is not bad. We are not against to use the medicine, the pharmacologic treatment, but what about to reach first the root cause of our chronic disease, when this chronic disease is not caused by virus, not caused by a bacteria, but it's caused by the lifestyle. So lifestyle medicine came as a response to this problem that I used to encounter in my daily practice. And of course, we can blame we can blame our genetics for many things, but we know thanks to epigenetics that the lifestyle pulls the trigger. So all my time in the past 10 years I dedicated to advance and to implement and to promote lifestyle medicine in education system and in practice system in Romania and in Europe. Okay, I don't want to talk too much about this because actually somebody else is more, more proper to talk about lifestyle medicine. And this is my surprise now coming. I'm delighted and honored to share with you the presentation of Beth Freitas. I would call her the mother of lifestyle medicine, an outstanding leader, pioneer in this field. She invested her lifetime energy and resources to help other physicians and professionals to educate themselves and to advance lifestyle medicine. So I will play her presentation because it's talking better than I can do in this way. So I just want to prepare the, okay. 6 minutes presentation of Dr. Beth Freitas, Harvard University, a very dear friend of us and our dear mentor in Romania and all over the world. Okay, I will need the host assurance that the video is...
Welcome, I'm Dr. Beth Freitas, and I'm delighted to be with you today to share information about lifestyle medicine and the American College of Lifestyle Medicine. I am an associate professor part-time at Harvard Medical School and the immediate past president of ACLM. In our 6 minutes together, I'm going to give you a brief introduction to lifestyle medicine, the definition and the history of ACLM. I'll demonstrate a couple of different options for teaching lifestyle medicine in the education continuum. Let's start with the definition of lifestyle medicine from the American College of Lifestyle Medicine. The website is lifestylemedicine.org. This definition was updated in 2022, and I'm delighted to share with you. Lifestyle medicine is a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions, including but not limited to cardiovascular disease, type 2 diabetes, and obesity. Lifestyle medicine certified clinicians are trained to apply evidence-based whole person prescriptive lifestyle change to treat, and when used intensively, often reverse or put into remission these chronic conditions. Applying the 6 pillars of lifestyle medicine, which include a whole food, plant predominant eating pattern, physical activity, restorative sleep, stress management, avoidance of risky substances, and the use of positive social connections, also provides effective prevention for these conditions. These are the 6 pillars in a puzzle piece graphic from the American College of Lifestyle Medicine. I'd like to share with you another graphic overview of lifestyle medicine from the ACLM, March 2024. This graphic shows you that we see lifestyle medicine as the foundation of health and healthcare. We collaborate with primary care physicians, specialty care physicians, and the sciences. And we take into consideration the social determinants of health, mental health, physical health, as well as social health. I'd like to share with you a brief history of the American College of Lifestyle Medicine and the American Board of Lifestyle Medicine, International Board of Lifestyle Medicine. First, you need to know that the American College of Lifestyle Medicine was created in 2004. It was in 2010 that the JAMA article, which revealed the core competencies of lifestyle medicine, was published. And then 2 years later, the American Medical Association had a resolution. They adopted a resolution that called for all physicians to acquire and apply the 15 clinical competencies of lifestyle medicine, which were reported out in this JAMA article, and to offer evidence-based lifestyle medicine interventions as the first and primary mode of preventing and, when appropriate, treating chronic diseases within clinical medicine. 3 years after this AMA resolution, the American Board of Lifestyle Medicine, the International Board of Lifestyle Medicine was formed. And then 2 years later, we created the first ABLM Lifestyle Medicine Certification Examination. I'm delighted to say that I am honored that I was one of the 4 item writers for this exam in 2017. Shortly thereafter, we had the 2018 Lifestyle Medicine Specialist Fellowship, and then 2019 Maintenance of Certification was introduced. We do have several thousand now diplomats of lifestyle medicine. They have been boarded by ABLM or IBLM. There are 6,293 worldwide, 3,810 in the US and Canada. And then you can also be board certified if you are a professional, a clinician in healthcare, a nurse practitioner, a PhD, a advanced practice provider. You can see all the different hubs for the International Board of Lifestyle Medicine examination here. There are core competencies for our exam, which are noted here. You can see them as I am clicking through the different core competencies and the weight for which they are held for the examination. I will turn to the educational offerings. We have a spectrum of lifestyle medicine education here, the bachelor level, master's level, doctorate, PhD level, as well as MD level, then residency level offerings, fellowship, CME, CE, maintenance of certification, and of course, certification. So we have academic test books, which you're familiar with, lifestyle medicine book from James Rippey as the main editor. This is a large 2,000-page textbook for our specialty. And then we have the Lifestyle Medicine Handbook, which I am a co-author, and all my proceeds do go to the American College of Lifestyle Medicine. This is a shorter 200-page book for you to enjoy, and all of the proceeds will go to ACLM, as I mentioned. We have the Lifestyle Medicine 101 curriculum, which you can download at lifestylemedicine.org. Several faculty have already downloaded them. And lastly, I want to share with you the strategies that we have and the educational spectrum with pre-college, college, graduate education, medical school, residency, fellowship, and CME noted here for you to see the different resources you can use. This is from the Mayo Clinic proceedings article that I co-authored in the fall on lifestyle medicine education. Lastly, I'll share with you this slide that shows you all the different offerings from ACLM for CME, CE, and maintenance of certification. Please note this free one right here, Lifestyle Medicine, Food is Medicine Essentials. And there are steps to certification, which I've outlined for you on this slide. I hope that you'll look into that. And thank you so much for your time. I appreciate that you included me today.
Okay, I hope this information help the audience to figure out how to educate themselves in this amazing field of lifestyle medicine. Okay, now I will share with you. Okay, sorry.
Sorry.
You go ahead.
No, I'm sorry. I thought that you were at the finish of your discussions. Sorry for interrupting you.
No worries. I just want to share again some other organization in Europe, because we are addressing the people in Europe. So in the case they are interested to join the European organization, I just want to quickly share this. Just a second. Okay. 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 So, if you can confirm me that Lifestyle Medicine Global Alliance website is in front of you, I will be very delighted.
Yes, we see the website.
Okay. So this is the Lifestyle Medicine Global Alliance, and you can see some, sister organizations that are listed here, depending on what countries are you coming from. You can see listed your organization here, or if it's not yet, maybe you can start building by yourself with the support of our international friends. I also want to share that some big steps in terms of lifestyle medicine policy were done in 2024 when in Doha, in Qatar, there was a meeting of plus 25 leaders in the world that were talking about the importance, the urgent need of the government to implement lifestyle medicine in the med schools and in the education system and in the practice, of course. So if you are curious to learn more about our declaration, please go on this website and just print this declaration, and you'll be able to use it if you want to reach your university or your municipality in terms of attracting their attention. I also want to introduce you the European Lifestyle Medicine Council, and this is the European organization that is composed by the representatives of the countries that are members in the council. I'm very proud to say that we are working with so many organizations in Europe, and also if you want to see what is the current component of this European Lifestyle Medicine Council, feel free to check if your country is listed, or if not, please get in contact with our leader there, Dr. Rob Lawson. I also want to highlight the thing that somewhere in beautiful country of Greece, in Leros Island, there is an outstanding leader, a distinguished professor in lifestyle medicine, Labros Dosis, who is leading this wonderful Mediterranean Lifestyle Medicine Institute. So this is a very interesting project that started some years ago, and me, Catalina, and Simon were privileged enough to be part of this ever since the beginning. If you are interested in the mission and the objective of this Mediterranean Lifestyle Medicine Institute, please Google Professor Labros Dosis and get in touch with him. Okay, this is all from my behalf. I will ask my dear colleagues to continue the presentation about lifestyle medicine, and to continue with some information in the case I skipped it. Thank you so much.
Thank you, Dr. Emanuela Mercore Huțanu, for all this information. I'm very sure that many internal medicine physicians are very interested in lifestyle medicine, and they will search their association. Also, thank you very much for introducing us, Dr. Bess Freitz. It was a very interesting from the Harvard University. It was a very interesting presentation. As we agree at the beginning, we'll have time for discussion after all the three presentations. So now I'm very pleased to introduce the second speaker, Dr. Catalina Figueroa, the co-founder and past president of the Chilean Society of Lifestyle Medicine, and she will talk about why lifestyle medicine matters in internal medicine. Thank you very much.
Thank you very much for to the organizing committee for having me here. I will just share my presentation, and so yeah, do you see it? Yes. Yes, thank you so much, and thank you to everyone joining this webinar. I'm quite excited. I'm really thankful for this invitation, because well, this is combining two of my passions. My first love, internal medicine, it is really my love, and then my second love, lifestyle medicine, and I very much believe that they can lead together and in our practice, and that's what I want to share today with you, a little bit of my experience and my journey ever since I finished my residency in internal medicine, and why I'm so passionate about applying lifestyle medicine. Maybe what I can say at the beginning is that the Americans, and as Dr. Beth Freitas shared, they consider this a specialty per se. It's also a discipline that can be implemented in any other specialty. So it's also good to keep that in mind, because we all need to know the skills that we can implement in lifestyle medicine. So that's very relevant. So I will start sharing a bit of my story. So I'm from Chile. This is a very long and narrow country in South America. And I'm from the south of Chile, but I lived many years of my life, and I did all my studies in Santiago, in the capital of Chile. So that's where I did my 7 years of med school first, and then my 3 years of internal medicine residency in this university. This is in the city center. It's a very old university for our Latin American standards, of course, and one of the most important ones. And next to it is the building of the academic hospital. And to me, this training was really magnific. I'm very grateful for all that I learned there. But I can also share with you, and I'm not sure if many of you can relate. I'm not sure our audience in which level of your profession are you now, if you are still in your training, in your residency, or you're already finished. But to me, the internal medicine residency was one of the most stressful moments in my life. I was quite burnout at the end, not only because of that, a lot of things going on. Then I also didn't like to live in such a big city, a big capital. So when I finished, I took the decision of moving back to the south of Chile. And this is the region where I was based in my last years. This is the lake region, if we can call it. Well, I was living in a city called Puerto Varas, if you can see it in the map, by the lake. But what I'm highlighting here is the biggest city, which is called Puerto Montt. That's the main city of this region, and it's the one that has the biggest hospital where all the specialty care is happening. So basically, every patient in the whole region that needs specialist care, including internal medicine, general internal medicine, let's say, had to go there to see the physicians, or for more complex hospitalizations. So I was working there mostly. And on top of the clinical care, I was also having students. Here, if you can identify me, I'm in the center of the picture, still with a baby face by then. I was teaching semiology. So this was very nice what I could do. But if you can notice in this map, what I also wanted to show you is that this is a very, maybe you don't notice so well, but this is a very big region. And if you notice the geography, you have the sea, you have fjords. So reaching every other city and every other part of this region was not so easy. So it was quite isolated in many of these cities. So what I was doing is not only to work in the big city, in the big hospital, Puerto Montt, but I would go every week, for instance, to the cities that were by this lake. So I would go to one city called Frutillar, another one called Yanquihue. So these are smaller hospitals. They were run by general physicians, and by general physicians, I mean not the GPs with the training for family medicine, but doctors who did only med school and then had to go there. And they were serving these very rural communities and with lower levels of education. So I would go there to support. If you want to see, well, this is the view that you can get in the city, so I couldn't complain. You can see 7 volcanoes from one of these cities. And other than that, I was also serving this part of the region, which is more isolated. You can't reach it with a car or bus. There's no highway there. You need to go across the fjords, or it's really isolated. It takes 1 day of traveling. So for the patients that were there, it was really complex to travel to the hospital, to the main hospital when they needed it. So what I was mostly doing is telemedicine. So through video conferences with the physicians there, we would try to solve the cases for internal medicine. And I really like that. Other than that, I was doing at least once a year some rounds. I would need to travel like with this charter only when the weather allowed it. And it was also not my favorite way of transportation. I'm not afraid of flying, but these small charters, and then whether the weather unpredictable, I don't know, sometimes I feel that I like to stay in the ground. So when that was not possible, we would take the ferry. It would take us an entire day. Don't get fooled by the pictures because this is taken on a very sunny summer day, but the weather was not like this all the time. But that was kind of the reality. And I would travel to these cities, which were much more isolated, and cross through the border with Argentina. And then we would try to solve the waiting list for the internal medicine and all the subspecialties. So just so you know, these cities are quite isolated, but also they suffer these natural disasters very often. In particular, this one has a volcano not next to it, but in the city. So this happened about 15 years ago. The complete city was destroyed. The people want to stay living in the city, even though there's a risk that another volcano eruption can come anytime. But this is the reality. So they are really resilient, but they are very poor from a very low level of education. So I shared all this context with you because maybe it's very different compared to what you are doing at the moment, but we all have our stories, and same as Emma, Dr. Emanuela was sharing her story, we all have a reason why we want to do more. And I can share with you that at the beginning I had such a happy working life. On one hand, as I told you, I love internal medicine. I think very much like a nerd from my first year of med school, understanding the physiology, making the diagnosis, managing the patients with multiple diseases. For me, it's really, truly one of my passions. So I really enjoy it, and the contact with the patients as well. On top of that, I felt that doing medicine here in this context was challenging, but it gave me such a feeling of being truly useful and impactful. I was not only reducing the waiting list in terms of seeing it a list of patients, but I was seeing it in front of my patients, and just contributing to that gave me a lot of meaning, which I think it's very important for all of us in our working lives. And then also being able to support my colleagues, these general physicians, with little training that sometimes felt like doing war medicine when they were so isolated in the winter. They couldn't transfer the patients. They needed to deal with maybe a woman coming in labor suddenly, unexpectedly, with complications, and just deal with it. So having support from someone coming with maybe more experience and expertise in certain topics, that was really useful, I think. I also enjoyed very much this nomadic working life, at least at the beginning of my career. Also the beautiful landscape. Sometimes I would just go to the cities, arrive to the hospital, have the sunrise by the lake with the volcano in front, just stop for 1 minute, just breathe. And that was really amazing. And also when I was doing these rounds, take the weekend off, do some hikings in Patagonia. That was very nice, I can say. And finally, I'm not sure how it's the reality in Europe. In Europe, I guess it varies per country, probably in terms of the funding you get for your residency. But for me, was not a lot in my residency. It was just like a very small scholarship. So after 10 years of med school plus the residency, finally having my own salary and being financially independent was great. But now I promise that there's a connection with lifestyle medicine, and I'm very aware. So this was happy, but there's always a but, right? Maybe especially for people like me, like many of us, maybe you can relate, but those of us who want to change the world, and we get frustrated a lot when we can't really create more meaningful change. So what happened to me is that I noticed that I was seeing mostly patients with recurrent hospitalizations. So most of them had advanced chronic diseases. Let's picture this elderly patient with advanced chronic kidney disease, not on dialysis, but then also heart failure, with diabetes, and then very difficult to manage their conditions, balancing the fluids. And then so you would discharge the patient and they will be back in 3 days. And you felt like maybe like we were arriving kind of late. On top of that, when I was in the outpatient care and they were referring a lot of patients so that I could see them and provide the specialist care. Sometimes, okay, I think I had very nice clinical cases. I could contribute a lot. But most of the time, what I was seeing is they were referring me the diabetic patients that were out of control. But then when you received them, they had a glycosylated hemoglobin of 10, 11 for years, for 10 years maybe, very late stage. There was little I could do. All I could do was maybe to adjust the insulin, maybe get a better insulin treatment from the main hospital, avoid the hypoglycemias so that they could get a better quality of life. But again, I was having the feeling we are arriving late. I think I want to prevent people from reaching this stage. And what can I do? On the other hand, maybe sometimes I had younger patients, a lot of referrals for gastrointestinal complaints. And then they were referring them so that they could get a colonoscopy maybe to rule out as maybe certain more severe conditions. But at the end, most of them had chronic constipation because they didn't have a diet rich in fiber and they were not doing a lot of physical activity. And there was very little I could do. Why? Because on one hand, this was a very rural and a low education setting. So this idea that we have, and now we talk a lot about this in lifestyle medicine, about empowering the patient and the shared decision-making process, because the patients are experts on their life and we are just coaches, let's say. It was very challenging in this setting. The patients really expected the authority of the doctor to tell them what to do exactly, and they couldn't think about other options or what they wanted actually. And also, it was very difficult. And I think this is not only in the context where I was working, probably you're facing similar barriers. There were system barriers. So short consultations with the patients, you don't have enough time to really provide all the holistic care that you would like to provide. Half of the time I had to spend it with a heavy paperwork. And then the hospital, of course, is telling you that your focus has to be meeting some targets because they are monitored by the Ministry of Health in terms of reaching certain targets with the patients, which are the most relevant things. Okay, blood pressure control, having the glycosylated hemoglobin on the target, regardless of doing this with lifestyle or insulin, which is usually the easiest option if you only want to focus on that, right? So that was my bad. And I was thinking, by that time, we didn't have AI or ChatGPT, but we did have Google. And I was really frustrated. And I said, it can't be only me, the only one willing to do something else. But I went into Google and I found and discovered lifestyle medicine. So what happened next is that I found it, and the next conference was happening in the US in 2018. And I traveled to Indianapolis, a random city for me. And I discovered that there was more people like me. It was the first time I felt like I found, let's say, my tribe. And I was so excited that I could maybe create some change that I went next year, this time to Orlando, to get certified by the International Board of Lifestyle Medicine. So now, after sharing my story, I would like, I forgot to say, also this certification connected me to some Chilean colleagues. They were also passionate about it. So in 2020, when the COVID was starting, we founded the Chilean Society of Lifestyle Medicine. And these pictures are, of course, after COVID, for our first conference, when we didn't need to wear these face masks and be there together again. So that was, for me, amazing. And what I wanted to share with you in the last minutes of this presentation is that lifestyle medicine was the way to repurpose my clinical practice, even though I felt it had a lot of meaning because of what I shared. And why is that? And why I think that for all of you, probably lifestyle medicine should be part of what you do as internist. So on one hand, for me, lifestyle medicine gave me a better understanding of the scientific evidence, because we study in medicine, I'm sure you've studied this many times, we have clinical guidelines telling you what to do with certain conditions, how to manage chronic conditions for most of the diseases that we see in general internal medicine or in any of the subspecialties. But the truth is that we don't really give the lifestyle part the importance, even though it comes as the first pillar. So just to share maybe some of these, this is from the Netherlands. It's where I live now in the Netherlands because I'm doing a PhD. And here, this is a report from last year. They actually share how they analyzed all the clinical guidelines that they have there, and more than half of them includes lifestyle recommendations. But are we actually implementing that? That's a different question. If you see that, you are not going to go in detail, it's not important, you don't need to read this, but I'm sure you all know this. This is from the American Diabetes Association. So this is the algorithm for you to choose, okay, which medication for our diabetic patients. On top of this, the main pillar is healthy lifestyle behaviors. But what do we do about it? We know this for decades. This one is from 2025. But I mean, this has been in these guidelines for many, many years and decades. And still, do you feel you have the skills? Do you feel you have the time to really empower the patient in this pillar? It's not so easy, right? Then you can see primary prevention of cardiovascular diseases. Again, this is an American guideline, but you can see the same in the European one. Here is a summary of all the pillars of lifestyle medicine, how they are included in the different guidelines for the different cardiovascular conditions. And you can see that there's very strong evidence for some of the pillars, especially nutrition, physical activity, smoking, but then also emerging evidence for the sleep, the stress, the social connections. And that's probably because this was not very researched at the beginning. We didn't give it importance, but now more and more. Asthma, this is an example from the British guideline. It's not only about avoiding smoking, but keeping a healthy weight, healthy eating, the physical fitness, all that is important. It is in the guidelines. For cancer, for prevention, and the point is not that we go into details, but it's also there. And then if you go farther, maybe this is something that we haven't learned so much when we have studied our medicine, is that also there are therapeutic indications for cancer, in prostate cancer, breast cancer, colorectal cancer. So some lifestyle interventions, especially in terms of diet, physical activity, they can reduce the recurrence of the cancer. They can improve the survival, which is very, very strong. So there's scientific evidence, but the problem is that it's not so easy to implement. Again, if you go farther, rheumatic conditions, it's also here, like you can read all the recommendations related to lifestyle. And we know it's important, but it's always like the last priority, I would say, in general, in the clinical practice. So the other question and the other thing that lifestyle medicine gave me, and I think should be important in your practice, is how to turn the scientific data that we all know into better patient care. And this is the other skill that lifestyle medicine gives you. And I'm not going to talk a lot about it because after my talk, you will hear Simon. He will give, I'm sure, a fantastic talk about health coaching. So he will explain you more about this. But the skills for really promoting behavior change and understanding your patient, the person that you have in front of you, it's so important. And also the context where you're working in, because that's something that you need to consider. So as I said, I'm not going to talk about this, but I will mention 2 points that I think are relevant in terms of these skills. On one hand, don't forget that your patient is part of a system. So it's not only about telling them what they need to do. You need to understand their cultural context, their education level, their health literacy levels, their family, the social support, the healthcare system where you're working, as I mentioned, the finances, the policies that you have in the country where you're living, if they live in a safe neighborhood and they can go walking in the neighborhood or not, and so on, so many things. So don't forget about that. We could spend another at least 20 minutes talking about this. It's not the idea for now, but that's very, very relevant. And finally, the other thing I would like to mention is don't forget that these are the 6 pillars of lifestyle medicine and the 6 pillars that you can apply with every single patient. But oftentimes in the guidelines and in like the theory that we have as physicians is that nutrition and exercise are relevant. Then substance abuse, when it's applicable for certain conditions, we always think of smoking or alcohol sometimes. But then the other 3, we often forget them. And what I wanted to emphasize here is that they are relevant, kind of intrinsically relevant because they are related to health outcomes. But don't forget that they also influence the potential for achieving changes in the other pillars. When you want to create change in a patient, if they are stressed, probably that's the first thing you need to address before thinking of advising them to improve their diet. If they are not sleeping, and I think we know this because we do a lot of night shifts when we are internists, right? At least as part of the training. So if you're chronically sleep deprived, it's very challenging to do changes. So maybe let's try to see how we can fix that. And if there's no social support and the person is so lonely, they don't have a purpose in life, it's really difficult to find the motivation to make changes in the others. So don't forget that those are very, very relevant. And finally, my last message, this is just like covering a lot of topics and I'm really looking forward to the discussion, but I really wanted to emphasize this one. For me, this has been one of the most relevant ones that lifestyle medicine has given me, and it's a tool for my own self-care. Let's not minimize the burnout that we need to face when we are in the training and the burnout that we see in the healthcare professionals nowadays. The healthcare systems worldwide, no matter which country you choose, they are really, really threatened by this. It's very challenging. So there's a lot of burden because, you know, the people are aging and then not in good conditions, a lot of chronic diseases. So it's really difficult. And learning this and applying that to myself has been very, very important in my journey. So just to share something, this is an example of a study. For me, it's very beautiful to see this, that lifestyle medicine practitioners implementing more lifestyle medicine in their clinical practice experience less burnout. So it's about more professional satisfaction, less stress in your own lives. It's more meaningful because you really feel that you are providing more quality of life and more satisfaction to your patients. And I think that's very important in this profession where we often learn how to impact the like harder outcomes, let's say. And then we tend to call these softer outcomes when we talk about patient satisfaction or quality of life. Maybe we should change that terminology because sometimes that's the best change that you can do to your patients. So I'm reaching the end. So as a summary, I would like to share with you my ideas about how you can implement lifestyle medicine in your clinical practice as internist. So if you are mostly working in the emergency room or hospital care, I think what you can do is to plant the seed for change. Most of the patients that are hospitalized or they are going to the ER is because they are facing maybe life-threatening conditions, or maybe they are not life-threatening, but they think they are life-threatening. And it's the moment when they question everything. And that's the moment when they want to find the motivation and change. So plant the seed. It's not that you can do a lot because let's face it, we have little time with the patient, but you can really create that and emphasize it. If you're even also in the ICU, maybe you're not going to work directly with the patient at that moment, but you can plant the seed in the family members, the family visiting the patient. So that's also something that you can consider. And when you are in the ambulatory care, this is the moment when, depending on your practice, the time you have with the patient, and the type of patients you're seeing, but this is when you can implement more goal-oriented patient care and discuss the goals in terms of lifestyle. So I think this is where you can implement a lot of the skills that Simon will share with you for health coaching, understanding, of course, the context of each patient. Then sometimes the only change or the only thing that we can do, but maybe sometimes it's enough, is to ask the patients if they want to discuss their lifestyle, how is their lifestyle. And when they have the motivation, you don't need to do it all. You can work together, you can partner with a lot of people. Also, lifestyle medicine, it's called medicine, but it's a multidisciplinary discipline. So you can refer patients either to educational resources, to a colleague that can do the nutritional education, or to an established lifestyle program. So create an inventory of places where you can refer your patients and have them at hand. If you have extra motivation, as like Dr. Emanuela, I think she's really an extraordinary champion, you can really become a lifestyle champion. And you can really advocate for change in your own hospital. If there's nothing, if there's no lifestyle program, if no one is really taking care of these, you can try to create change and maybe create the lifestyle program for your patients or something else. Train some of your colleagues. So you can really do a lot. And finally, if you want or can build your own lifestyle practice in private, like a private practice, that's also the moment when you can set your own rules. If you want to have a 1-hour consultation with your patients and do the chronic management for the diseases like as we do normally as internists, and then also provide the lifestyle care, you can of course do it because that's also part of setting your own rules. And by the way, that's what I'm doing now that I'm in the Netherlands. I'm based, so I'm doing internal medicine, lifestyle medicine with patients through video consultations with Chile. So that's the very end. So just as a summary, why lifestyle medicine matters in internal medicine, these are my thoughts. It's because we are not just treating diseases. This is a tool to help patients to live healthier, fuller lives. And also because it's a tool for us, providers, for our own self-care and resilience. So thank you so much. And I'm really happy to answer any questions and discuss, and please share your experiences and how you heard about lifestyle medicine. Share your journeys with us. Thank you.
Thank you very much, Dr. Catalina Figueroa, for sharing such a comprehensive perspective on lifestyle medicine and for highlighting your inspiring journey in integrating lifestyle medicine with the practice of internal medicine. We've seen the questions in the chat, but we remind you that the speakers will answer the questions after we finish the third presentation. So I'm pleased to introduce Mr. Simon Matthews, a psychologist, fellow of the American College of Lifestyle Medicine, certified by the International Board of Lifestyle Medicine, and holder of a master's degree in health science degree. He's also a faculty member at Avondale University and the Well Coaches School of Coaching. So today, Mr. Matthews will present the topic, the role of behavior change in lifestyle medicine. So the stage is yours. Thank you for being with us.
Wonderful. Thank you, Elena. Good evening, everybody. Welcome to you wherever you are. Thank you, Emma and Catalina, for your work. I've known Emma for several years. I haven't known Catalina for quite as long, maybe a couple of years. Catalina and I actually grew up very, very close to each other. So Catalina showed you that map where she lived in the south of Chile. You can see there that she was just on the eastern edge of the Pacific Ocean, and I grew up just on the western edge of the Pacific Ocean. So we were not that far apart growing up, but we didn't get to meet until a couple of years ago. And now we live in a very similar part of the world. Although I grew up in Australia, I now live in Madrid, Spain. So I'm, along with Emma and Catalina, I'm in Europe as well. So I get to do what I think is the most exciting job in lifestyle medicine, and that is, number one, to teach physicians and other allied health professionals about health behaviour change, and also to accompany patients in their health behaviour change journeys as well. I'm going to encourage all of you. I'm making this a bit of a teaching session, so I want you to walk away with some practical ideas that you can put into practice straight away. So do feel free to have your smartphone ready to take a picture of the slide or take a screenshot of the slide if you would like to as well. And do feel free to type questions in the chat about anything that I share, and I'll be happy to answer those questions at the end. So behavioural change, I think, is the most important element of lifestyle medicine, because most of the places where patients struggle are not to do with biochemical things. They're not to do with what goes on internally. The places where people struggle are to do with their behaviours, the things that they do in daily life. And so if we don't introduce behaviour change into lifestyle medicine, everything that we know about lifestyle medicine, everything that we know about diet, about sleep, about exercise and activity, about social connection and so on, all of that just becomes interesting information if we don't have a means to help people to put that in practice. And one of the important things that a behavioural change perspective does is it helps to connect the need that a person has with the outcome that they get. This idea of needs is something that I really want to implant early and have you thinking about deeply. We are all of us are driven by our needs. All of our behaviour is driven by need. Why are you all here this evening? Because you need to know something about lifestyle medicine. Why did you go to the grocery store today? Because you needed to buy some food for dinner. Why do you go to the dentist? Because you need to look after your teeth. Why do you go to the shoe store to buy shoes? Because you need shoes to be able to do what you want to do, and so on. All of our behaviour is driven by need, and it's important that we remember that in healthcare as well. So understanding and being able to translate our language, our medical language, into behavioural language is a very important skill here. You, as a clinician, might think about a level of HbA1c or a level of LDL-C or HDL-C or something like that. That rarely means anything to your patient. Your patient's need is to be able to play with their children, play with their grandchildren, travel, to be able to walk comfortably and strongly up a flight of stairs or up a hill, to be able to play tennis with their friends, to be able to go out dancing at night, whatever that might be. That's what we really need to help our patients to be able to do. So therefore, when we talk about behavioural change, we're really talking about engaging in what I'm calling identity consistent actions. And by that, what I mean is we're doing things that match up with how we see ourselves and how we think about ourselves. If I want to think about myself as someone who is a lot of fun to be around, then it's important that I act in a way that's consistent with that, and I'm a lot of fun to be around. If I want to think about myself as someone who enjoys traveling, that it's important that my behaviours match up to that as well. Being able, therefore, to work with someone to help them to monitor those behaviours and make sure that those behaviours are staying aligned with what their needs are and how they see themselves is the heart of behavioural change in lifestyle medicine. I want to, at this point, though, tell you about what the most important factors are in behavioural change. And this research is very interesting. I won't go into it in detail. I'm certainly happy, if people want to ask a question, happy to provide you some other information about this. This is called the Common Factors Research. And the Common Factors Research has been around for about maybe 80 years now. It began in therapy, and now it's emerged in behavioural change in healthcare as well. Common Factors Research tells us that the biggest and most important factor for patients in being able to manage and modify their own behaviours is their own resources. their own internal resources and their own external resources, and importantly, their capacity to develop those. So when we talk about internal resources, we're talking about strengths, we're talking about values, beliefs, attitudes, skills, personality characteristics, and so on. When we talk about external resources, we're talking about perhaps people who support them. We're talking about some of those social determinants of health that Catalina mentioned. So, so the community in which you live, the resources available to you in that community, the amenity of your community, and so on. That is the most important lever. That's the biggest lever that we have in behavioural change. If clinicians get very, very focused on something like or cognitive behavioural therapy, if we think that that's what does the work, then we miss these opportunities to harness these elements of behavioural change. The next biggest factor is what gets called the therapeutic alliance or the coaching alliance. In other words, the relationship that you have with your patient. Are you warm? Are you engaging? Do you smile? Are you approachable? Are you interested in your patient? Do you give expressions of care? Do you show that you want to understand? Do you show that you do understand? All of those things contribute to the therapeutic alliance, and that alliance or that connection makes a big difference to the patient experience. Those two factors together, the patient's resources and the therapeutic alliance, they account for about 70% of the outcomes that we see in behavioural change. The remaining 30% is accounted for by the particular technique or approach that you use. And one more very important thing, which is your capacity to support your patient to feel hopeful and confident that change is possible. So it's very important that we use language that demonstrates that. We use language that shows that there's an opportunity here to do something different. There's an opportunity to be different. Other people I've worked with have done this. You can do this too, and so on. So common factors research, common factors theory is very, very important. And the most important part, the resources that your client already has and can develop themselves. Make sure you pay close attention to those. If we dig a little into some of the other important theories in behavioural change, there are two that I want to mention briefly. The first is self-determination theory. This is about a 40-year-old theory, and it helps us to understand, again, the factors that make a big difference. The biggest factor, autonomy, allowing the person to choose themselves. Catalina mentioned this. She mentioned this idea of our patients being the experts themselves in who they are and what they want in their lives. They're not necessarily the experts in the knowledge of perhaps what foods to eat or what foods not to eat or how much sleep to have. We can share that knowledge when it's appropriate, but they are the experts in the choices that they want to make and the things that are most important to them. So it's important in all our work that we give our patients choice about what to do and how to do it. The second important element is competence. Competence is about how much we have the skills to be able to do something and how confident we are to engage in that process of change. That connects with hope, it connects with knowledge and information. And the third very important principle is what gets called relatedness. In other words, connection. So interestingly, this is one of the pillars of lifestyle medicine. This is the social connection pillar. We have a lot of research that shows that people are much more likely to sustain a behavioural change when they're well connected to and well supported by other people, including you as a clinician. So taking the time to support your patient to build those connections is really, really important. The other very, very important theory in behavioural change is self-efficacy theory. This was the work of a psychologist called Albert Bandura, an American psychologist who only passed away during the pandemic. Actually, he was about 90 years old. Self-efficacy tells us that people will take a step forward when they expect to be successful. They're less likely to take a step forward if they're unsure or if they think it's going to fail. This is why helping your patient to be confident and hopeful about the future is very important. We can support the development of self-efficacy by working with patients to set small goals, by acknowledging the small steps that they take, no matter how small they are, by helping them to regulate their own emotions. In other words, perhaps if the patient tried something and it didn't work so well, encourage that patient to think about this from a perspective of what they've learnt about themselves, rather than to get angry and frustrated with themselves that they weren't successful here. That tends to inhibit learning, whereas being focused on what can I do differently next time tends to regulate emotion and help efficacy. And there's some examples of questions down the bottom there that you can ask as a clinician. If you had a scale from 0 to 10 now, 10 represented where you want to be, where are you on that scale? Your patient might say 6 out of 10. So what does a half-point difference look like from where you are now? And ask your patient, when else have you done something like this? As soon as you ask that question, you're inviting your patient to think about their past successes, their skills, their resources, and we know that that's that really important factor in common factors theory. An important principle in behaviour change is that change occurs because it's meaningful to someone, because they want to do it, because they have a need to do it, because it connects with how they see themselves. Change typically doesn't happen because we're paying close attention to it and making sure that someone does exactly this, not that. And you can think about that in your own life as well. Think about a significant change that you made. Maybe a decision to go to medical school. Did you decide to go to medical school because you were watching very closely the options that you had and making sure you chose just this one? Or did you choose to go to medical school because it meant something to you, because it was important to you, because it aligned with how you see yourself, the values that you have in your life, and so on? So working to support your patient to connect with the meaning that they attribute to themselves and to act out that meaning is very important. You can see some other examples there. I want to be the grandparent who's able to play on the floor with my grandchildren. As we know, a lot of people, as they get older, start to experience limited mobility. Getting down onto the floor and, importantly, getting back up from the floor can be very challenging. Little children, grandchildren, spend most of their time on the floor. So if you want to be able to play with your grandchildren, that's where you've got to be able to get to, and that's where you've got to be able to get back up from. So this is an example of the way in which we need to connect the person's need to the way they see themselves, to the meaning that they have about themselves, in order then to bridge the link between that story that they want to tell themselves and the changes that are required in their behaviour in order to get there. There are some very important skills in behavioural change as well. I call them micro skills. They're the, if you like, they're kind of the DNA of behavioural change. They're the very, very smallest building blocks of behavioural change. The first of those is listening. And generally speaking, healthcare practitioners don't listen nearly as much as they should. We are all trained with a lot of knowledge, myself included, as a psychologist. And when I left university 30 years ago, I left with the belief that the most important thing I had was the knowledge in my head. And in fact, that's not the case. The most important thing I have is the capacity to sit down with a fellow human being and listen to their story and show that I've heard and understood, and show that I want to help them and support them in this journey. So my encouragement here is step number 1, listen. Step number 2, listen some more. Then step number 3, keep listening. And keep doing that until it starts to feel a little bit uncomfortable. When it starts to feel a little bit uncomfortable, you've probably listened enough, and then it might be time to share something with your patient to show that you've heard and understood what they've been saying. And that's the job of reflections. So reflections are phrases we use like, it sounds like you're feeling very confident. It sounds like you're feeling uncertain. I think I'm hearing you say you want to do this, and so on. Short sentences that show that we've really understood what the other person is saying. Then we might ask questions to help the patient develop their story more and tell us more about what's important to them. An example of how you might reflect and ask a question is just here. Let's imagine you have a patient who says to you, well, the problem with reducing my wine is that it really helps me unwind and decompress in the evening. So we might say, an evening glass of wine helps you decompress. There's the reflection. What else would make evenings feel a bit lighter for you this week? There's the question that invites the person to think a little more deeply about themselves and what else might be available to them. Along with those micro skills, it's very important that we pay attention to the right things to measure. And I can't emphasize this enough. Paying attention to what's important in measurement is the thing that gives us the right type of feedback about how we're progressing forward. If you're driving your car, if you're driving, say, from Madrid to Utrecht in the Netherlands, which I'm told is a very nice journey to take. What should you pay attention to there? What should you measure? Well, one useful thing to measure might be kilometres. Another useful thing to measure might be time. Is it useful to measure how many birds you see during that journey? Is it useful to measure how many yellow trucks you see on the road during that journey? Not really. They don't help you in your progress towards your destination. So we must focus on the right things to measure. So in behavioural change, there are several things that we need to pay attention to. Obviously, clinical outcomes, blood pressure, A1C, lipids, weight, and so on. They're important clinical measures for physicians. But in addition to that, we must focus on behavioural measures as well. How many challenges have you managed this week? How much are you progressing towards your goal? How many days have you practiced? How well are we staying focused on what's important to you in this process? They're all really important things to focus on as well. So getting clear about those really matters. I'm going to leave you with something to reflect on for yourselves, and this is something you can do next time you're in clinic with a patient, if you like. Ask this question first: what would make today's visit most useful for you? Make that the very, very first thing you say. Good morning. It's great to see you. What would make today's visit most useful for you? Secondly, if your patient describes a behaviour that they're saying is problematic, be curious about the function of that behaviour. How does that behaviour help them? For example, if they say, I've really got to stop drinking wine. Well, before you start giving advice about stopping drinking wine, ask them, how does drinking wine help you? Listen some more. Keep listening, show that you've understood, and then work with your patient to design an experiment that they may be able to try. Now, all of that's a very, very brief run through some principles of behavioural change. There's some citations there. Feel free to take a photo of that if you would like. Some citations there to get you started. Behavioural change is a whole discipline all in itself. I teach students the skills of behavioral change, and it takes many, many months and or years to develop those skills. I've been doing this for 30 years, 35 years. I still learn new things every day about this process. It's a lifelong journey. However, I do encourage you all, as you move forward in your training, to also be really focused on this idea of specifically and directly supporting behavioural change for your patients. Thank you.
Thank you very much for this very, very interesting presentation and very useful. We listen. We were very attentive at everything. And I think it was also the most difficult one, and in some ways, because changing the behavior is the most difficult thing, I think, in this for lifestyle medicine. I have a question that is the same for each of you. It is a question that you have already addressed in your presentation, but perhaps we could make a summary of what would be most important. So my question is like this: what are the most effective motivational strategies for patients resistant to change? And I saw that I have problem with 4 pillars of the 6. Only the 2 in the middle in Catalina image were good. The other 4. So I'm very interested to find out how to make to be auto-determinate, like Simon said.
The most important motivational strategy is the one that's going to work for the patient that you're talking to at that time. Now, I appreciate that that's maybe not the answer that you're hoping for. You're hoping for me maybe to say it's this particular strategy all the time, always. And it's not. We're all motivated by different things, and even all of us here. Everyone here, for example, is training as a physician or a clinician for a different reason. Some people do it because they had a personal experience in their family. Some people do it because perhaps this is what people in the family do. Maybe they come from a family of physicians. Some people do it because they've been moved by some world event that they want to be able to contribute to in some way. We're all motivated by different things. So the most powerful motivational strategy is the one that works for that person, and there's only one way that we get to find out what that is, and that's by asking the person. The easiest question to ask is this: why is this important to you? Why does this matter to you? When you ask that question, you learn straight away what's going to help motivate that particular person.
So the first clue is just to ask what is important. So just to ask the patient. Emanuela Mercore Huțanu, do you think otherwise? Or maybe you have something to add?
Well, we just listen to the most, experienced person in the world in terms of behavioral change. So I cannot add anything on that. Well, I can share also from my personal, experience. Of course, nobody has a perfect lifestyle. So if somebody is selling this idea that there is a perfect lifestyle, for sure is wrong. Because as both Catalina and Simon highlighted, the lived environment is the one that usually has a lot of impact on our choices. If you ask Professor Sidotis if we have a free will, he will answer there is no free will, actually. Well, I'm somewhere between, because I also have a lot of motivation for myself, for my family, for my patients, but very often I'm also falling out of the track, and I need to get the motivation back to go back on the track. If this makes sense to you, what I want to say is that there is no perfect motivation that we can use it every time we feel depressed or demotivated, because in different times of our lives, something else might motivate us. Maybe now, because I'm a mother, when I'm looking at my sweet child of mine, the motivation for a healthy lifestyle is to see him grow, to see him getting married and having kids. So I think if you were asking me some years ago, maybe the motivation was a little bit idealistic. But if you can narrow this idealistic, image of yours, and you can point it up to make it very realistic, that will be the perfect motivation. So my motivation for tomorrow is to have energy, and that's why I will, go very soon to bed after we finish. So let's take step by step, small steps, because otherwise, if you have to deal with the whole thing at once, can be very overwhelming. So I hope these thoughts are helpful, and maybe it will answer a little bit to your question.
Yes, thank you very much. And I have to tell a little secret that actually this is like a Romanian word also, that any grandmother in Romania is saying, I want to see my nephew like married or growing or university, I don't know, college, something. So this is something probably worldwide available, but also in Romania. So Dr. Catalina Figueroa is the same question, but because both you and Simon lived in many countries across the world, not only Europe. I would ask something. I would add a little question to the previous one. Are there any cultural differences in how lifestyle medicine is applied across Europe and Latin America?
Yes, I really like your question, Alina, and I think it's very much related to my answer that I wanted to give, because I wanted to share also my experience as an internist with patients going because of certain complaints and symptoms and conditions. And I really think an important strategy that worked very well for me, at least in Latin America, was to challenge on one hand the patient coming. It was very common to have this middle-aged man, really like the strong man, very Latino macho, they can't complain about anything, and they came forced by the wife. So they would come and saying, like, they told to me in my face, I hate doctors, I didn't want to come here. And then they would say, I would ask, okay, and what can I do for you, like and they would say, no, my wife, ask my wife, she's the one that will tell you, because I didn't want to come here. I think that's very much related to the Latin American culture. I believe that this is not so common in Europe, at least in the north of Europe, where I'm based. Maybe in the Mediterranean region, it's also common. But then what I would do with these patients, as Simon was really highlighting, to really listen and ask them, okay, what can I do for you? Because they would come thinking, no, I know what you're going to tell me. Like, all the doctors tell me that I need to start eating healthier. And I would say, no, that's not what I'm going to tell you. And then I would challenge this vision of the doctor being the authority, because this is what they are used to, and telling them what to do and punishing them if they don't adhere to the prescriptions that you give them, which is very common. I must say that in our field, it's still happening, that the patient comes back and they tell them, okay, if you are not taking the medication, just leave the room, because there's nothing I can do. In lifestyle happens the same. So I think challenging that role worked really well in my case in Latin America with a lot of these patients. And I very much believe that's a cultural difference. And then the other thing I would like to mention is that sometimes what can also work with patients with chronic conditions and complaints is linking the lifestyle behavior change specifically to the complaint that is worrying them. Maybe in your agenda is the fact that the patient has high cholesterol, and you really want to give them a better diet, but they don't care about that because they are very young. They don't want to think about the heart attack they will get in 20 years. But then maybe that same patient is having chronic constipation, and you can prescribe the same healthy diet, but really link it to what's worrying the patient, not what's in your agenda, but it's what it's in their agenda. So I think that's relevant, and I think that's very much common in Europe and everywhere in the world.
Alina, the other thing that I would add to that is that it's important for us to remember that culture has many, many layers. So we often, when we use the word cultural differences, often what we're unconsciously talking about is a difference between this country and that country, or this geographic region and that geographic region. But within countries, there are cultural differences. Within cities, there are cultural differences. Within little neighborhoods in cities, there are cultural differences. Within families, there are cultural differences. And the most certain way to be able to navigate cultural differences successfully is to approach every patient with a mindset of, I don't know who you are. The most important job for me is to find out who you are, and therefore ask questions and listen to that person's story about themselves. And when we do that, we navigate cultural differences at all levels much more successfully than if we walk into a situation with preconceived ideas about how to respond to or how to talk to different people in different settings.
Thank you very much for all your answers. I also have two questions for you. So the first one, I will ask from the shoes of a resident, and I will tell a story about the fact how I found out about lifestyle medicine. So I was a fourth-year medical student back in 2020. And I was asking myself why we learn so much about how to treat diseases and why we don't learn about how to prevent them. And similarly, with Dr. Figueroa, I did a random Google search, and I have written lifestyle medicine. And from there, like my journey and this field, I discovered this field. So if we have if our attendees are medical students or residents, what do you think, how do you think they should start their journey? Like what courses or where should they start, and how they can begin early their career, like in combining this medical training with lifestyle medicine? Thank you. Who is more comfortable to answer, please? Yes, Dr. Emanuela Mercore Huțanu, please.
Okay, if my colleagues are okay for me to take this question. First of all, please, I'm Emma. For us in this wonderful team, the titles are not anymore important. We are all friends in the first, first of all. And second, we are promoting a multidisciplinary approach. So for us, the doctor, who is who, doesn't care, doesn't count anymore. We are all having the same aim, the same mission, and we are empowered and motivated by the same, feeling that we must deliver to our patients more chances to live longer and healthier life, and to have, this life to be lived with a purpose and with a lot of, sense. Back to your question. Yep, I very much appreciate all the students, the medical students, the residents that are interested in this field. I can see myself in these shoes. And I want to mention that I didn't have the chance, but I will share real quickly the website of our organization. And I want to mention that even though we are, founded ever since 2018, a lot of colleagues from the executive board are on and off based on volunteering roles they have. But I want to highlight the fact that almost continuously, uninterrupted, the medical students' activity was keeping the organization alive many years. So I'm very grateful, and I will pronounce some names here. It's the Lidia Crețu, Alina Crăciun, Delia Apostol, the students that are behind the Romanian Society of Lifestyle Medicine, and they made this organization to be alive in the campuses. So what I want to highlight, you don't have to wait to get your title, to wait for your, graduation, or to get your specialization, or get the PhD. The moment was yesterday to learn and to implement lifestyle medicine in our personal life and careers. And don't forget that medical students are almost doctors, okay? Because I remember how proud I was with my white, scrubs. So I was feeling very empowered by that. And I had the burden of the responsibility already on my shoulders to read everything, because there were patients everywhere, in the families, in our friends groups. So no matter if you are a student or if you are a graduated doctor, psychologist, nurse, pharmacist, nutritionist, I think you should get immediately in contact with your organization from your country. That's why I was interested to learn how many countries are represented in this webinar. If you have any questions regarding, the existence of one organization, please reach us out. I want to say that the medical students are having the possibility to get involved right away in the majority of the sister organizations, lifestyle medicine sister organization life. And if you are in Romania, no matter what culture are you coming from, please get in touch with me directly. I'm very glad to welcome you, because for Romanian Society of Lifestyle Medicine, the students are top priority. We are investing as much as we can in their education. We are involving them in every single initiative or activity, no matter how intense, how difficult. And I think we can say that we are all colleagues. And yeah, please reach out to Romanian Society of Lifestyle Medicine organization. And sorry for that, but please let me share just a second the screen, and to share with you that we have under working website. So it's not finished yet, but you can see here some of our mission, vision, objective. You can learn from the ecosystem that is listed here. I was mentioning this organization today. Also, you can learn how to get educated in lifestyle medicine, no matter if you're a student or not. And some, details about our projects and our partners. Also, it was mentioned the American College of Lifestyle Medicine website. Please, if you are a student, also you can find ways of implication. You can become a a leader in your own campus, because they have a possibility for the students to work with the lifestyle medicine interest groups within the university, and you can get a lot of help. Okay, this being said, I'm welcoming everyone here in the Romanian Society of Lifestyle Medicine, Moldovan Society of Lifestyle Medicine, with my open arms.
Thank you very much, Emma, for this comprehensive explanation. So in conclusion, anyone who wants to join or to contribute, any healthcare provider who wants to start the journey in the field of lifestyle medicine can find his place in any way and in any country, because I guess there are a lot of European hubs that provide this type of education. And very shortly, because we are running out of time, another question. We've seen those 6 pillars. I guess that we as doctors don't have the training to cover all of them. How does the collaboration between probably a doctor and other healthcare providers, or like dietitians, psychologists, happen, and how open are the both sides to do this? Thank you, Simon Matthews, for raising the hand, and please answer.
I think there's two ways we can think about that. The first one is absolutely the multidisciplinary or interdisciplinary approach. I think is very important. That means for all of us, whether you're a physician, a psychologist, a dietitian, an exercise physiologist, that means actively building networks in the place where you work and virtual networks where that might be relevant as well. So in other words, prioritizing that is something really important to do in your practice. Construct a network of other professionals around you. And my personal experience has been that when practitioners do that with the intention of being able to support each other, that's always welcomed. The other important thing to do is to train in lifestyle medicine, to study lifestyle medicine, and to become certified in lifestyle medicine, because that certification does give physicians the skills, sufficient skills, to be able to work in that area. And I would encourage everyone here to, whatever specialty you're thinking that you might want to pursue, maybe it's internal medicine or obesity medicine or family medicine, go after that specialty with all your heart, and add lifestyle medicine to it as well, and pursue that as a specialty.
So as we are already at the end of our time, I would like to ask you if we have any, if you have a final message. So
maybe I can share with you just a final thought. I was just thinking that when we want to collaborate with others or inspire other colleagues to join this journey of lifestyle medicine, just like creating this change is also behavior change. So the same tools that we can apply with our patients to change a lifestyle behavior is that what we can use to change the behavior in our colleagues, in the managers taking the decisions in our hospital. So listen, ask, as Simon said, and then only then we can maybe convince them and have a bigger team to get on board. That's my final thought. And thank you so much for having us.
Oh, thank you very much. The most important message for the internal medicine physician is therefore to listen to their patients, to listen to all the problems, and not to just wait for the patient to come with the problem, to ask what is your problem or what are your needs, and try to understand, making a relation with the patient, not just giving a treatment. With this, we conclude today's webinar, The Connection Between Internal Medicine and Lifestyle Medicine, organized by the EFIM Early Career Group. So on behalf of the organizer, I would like to thank you all distinguished speakers for their valuable contribution, and also all participants for joining us today. We look forward to welcoming to our future events. Thank you all very much for a very nice evening.
Thank you. Bye. Bye, everybody. Thank you.